they lack a lot of radial strength. Boston Scientific is looking to come up with a dedicated osteal stent called Megatron, which is going to have much more radial force and not prone to longitudinal deformation as these stents. That should be interesting to see.
Hello.
Good morning, Dr.
Hello.
Kaul. Good morning.
Good morning, Dr. Behel.
Yes,
Good morning.
Very good morning to you from Delhi. And
we
how
have
are things in Chennai?
all fine. Just waiting to see your case.
Well, good. So, yeah. We had a little bit of anxious moments here. This gentleman is a 67-year-old diabetic hypertensive who had a PCI way back in 2003. Here only in Batra hospital, I had done it. LAD and obtuse marginal 2 were the targets that time, and drug-eluting stents were used. You remember drug-eluting stents came in 2002, so he was in 2003. I think most probably the stents were Texas stents. Now he was all right all these years and actually was not coming for follow-up for the last 2-3 years. A month ago, he had acute coronary syndrome and was treated in Jammu. The ECG there showed evolved anterior valve myocardial infarction and an ejection fraction which was about 35 to 40%. At that stage, he came here and we did an angiogram. And let's have a look at the angiogram. Angio from the beginning. So you can see he has a very long lesion in LAD in the right coronary artery, and the proximal portion of right is also diseased, although not critically. Next view. You can see it in the other view. Again, you can see that now this is the left coronary system, and as you can see, the stent is totally occluded. The circumflex has a complex bifurcation disease with one of the limbs having a severe proliferative in-stent restenosis, and just above the stent, there is a moderate-sized obtuse marginal coming, which has disease from ostium to maybe about 5 or 8 millimeters. So this becomes a very important vessel, and right coronary is also grossly diseased. His echo is low ejection fraction, thinned out left ventricle in the LAD area. He had a MIBI study, stress MIBI, which showed absolutely a scar in the LAD area and a significant ischemia in inferior lateral posterior walls. So from here we go. So we took this patient, did this angiogram just today, as you just saw. And at that stage, we saw that his saturations were coming to 80, he was breathless, and we were in a soup what to do. We immediately gave him all the resuscitatory measures, put him on an intra-aortic balloon pump, oxygen, and within 5 to 8 minutes, he settled down. And then once he settled down, we thought that we must open his right coronary artery first. Let's start the PTC procedure. So here is we have taken a hockey stick guiding catheter, crossed the lesion, we're dilating it distal to proximal with a 2.5 millimeter balloon, and then stented him using a 3 into 38 stent distally. Next. And then another 3.5 into 38 stent coming up to the ostium, because this was a situation of patient sick, and we wanted to do whatever is best to first to revascularize his right coronary artery quickly. And this was post dilated with a 3.5 millimeter balloon. And now that we were breathing better, with the patient also breathing better, did an OCT on him. at this stage. Can we have the OCT pictures of this right coronary artery, reconstructed right coronary artery? Just give us a second. Are you able to see the OCT images now?
Yes, we
Yeah.
can. We can see it clearly.
Yes. Yes. So we see a well-opposed stent. This is the pullback. Yes. All the way through it is well-opposed. This is a side branch coming more proximally. Yeah, very little tissue prolapse at one time, but otherwise looks good. So since it was 38 and 38, one run was not enough to look at the ostium. So we did another pullback, keeping the catheter a little more proximally to see what is the status of the ostial and the very proximal RCA stent. Okay. So the apposition looks quite satisfactory to me. Are you able to see it?
Yeah, and just two questions here. Upendra, of course, there was that distal area.
Yes.
I think that's the bend area which we was not very happy about. The distal, the area in the distal part of this
We
vessel.
dilated that with a 3.5 millimeter. We dilated that portion with a 3.5 millimeter balloon at 20 atmospheres.
Okay. And the other aspect is, of course,
So obviously there is a fibrous, yes, there's a lot of fibrosis, I think, around it, and beyond that, we're not able to expand the stent.
Fine.
Possibly a better preparation in the first instance would have been better, but I told you the situation in which we are working, a patient in pulmonary edema and, getting hypotensive,
absolutely agree.
supporting him. So with this, yeah. So in
Other
this
thing was-
situation, we're at this stage.
The other thing was you've done good high pressure dilatations anyway all around. You think that you could have actually saved on this contrast in a guy who's just gone into pulmonary edema and now you've got more work to do perhaps on the other side and you've
Yeah, I know, but
another 30
one
ml of
thing was good about him
25
was that
ml
his
of
serum
contrast
creatinine,
added.
serum creatinine is 1. One good thing about him was the serum creatinine is 1, and he's making good urine. We gave him 60 milligrams of furosemide, and he is passing good amount of urine. But I agree that we possibly could have saved 30 to 40 cc of contrast. Although these days we can also do an OCT with low molecular weight dextran. We did try it in one case last week. Did work, but we're not very happy with that, so we thought that we'll go ahead with our traditional method. So now let us come to next. Now this is our target now. Now, as you can see, this is a bifurcation Medina 011 with one of the limbs of the bifurcation having a diffuse instant restenosis and the other limb having this obtuse marginal which has ostium involved and also proximal. Can you get to the previous view? Yeah, with
For
the
discussion's
obtuse
sake,
marginal having
which
its
artery
ostium
you'd
as well as
like
the
to open first, the
proximal.
LAD or doing the circ? Any opinion from panel?
No. LAD we're not opening because it's, LAD is a scar.
There's a scar.
We have
That's
seen
why
it.
he's got LV dysfunction
Okay.
and pulmonary edema.
It is a scar.
Yeah.
It's
Okay,
a
so-
LV dysfunction and the whole behavior he had. It's a scar.
Okay.
It's a scar, thinned out ventricle on echo and thallium showing no uptake in that region and stress thallium showing ischemia only in inferior, lateral and posterior walls.
Okay.
So now this is the situation. So we plan to, do a bifurcation angioplasty on this. Patient is now stable. His pressures, in fact, are on the higher side. His augmented pressure is 125. Next. So we're going through with a whisper wire, had some difficulty, but finally did manage to cross this instant restenosis by a whisper extra support wire. Next. Yeah. And now we took a BMW wire to go into the Next. Okay, we're here now. Just take a picture.
Do we know what stent is that in the circ?
So this is it. So then we plan to dilate this instant
Most likely he
segment
said Texas
region.
stent.
You said this was done
First
in
we thought that we would
2003,
open the
probably
OM1
at Texas.
and the balloon, yes,
It's in OM1.
yeah, and the balloon,
It's OM1.
2 millimeter balloon did not go. So now we're going and dilating the upper branch that is the OM2 with a 1.5 millimeter balloon. Whether it has gone through a strut, we have to see because it is very close to the proximal end of the restenosis stent. So we're going now with a 1.5 millimeter balloon. Here we go. It has crossed, very good. This is what length? This is 10 millimeter? This is 12 millimeter balloon, single marker. So let's dilate here. Well, as you can see, with me, on my right side is Dr. Yadav, and on his right is Dr. Tahir, our junior consultant. Dilating this vessel. Now I think we'll go with the bigger balloon, dilate this, and then dilate the instant restenosed stent. And our plan, I think, because of the complexity and the severity of disease in the upper OM also, is to go with a two-stent strategy. Any thoughts? What kind of two-kind strategy would you like? What the panel discuss
over to
this
the
and
panel.
give their opinion to us that
Could we see the
what
distal
kind of
vessels?
strategy
We are not
should
seeing the
be,
distal OM. How big are the
in
vessels?
their view, the best strategy in this patient?
It's a moderate size, I think.
Probably
You
tap.
can see in previous angios. He's asking what
Just
size
show the
is that?
previous angiogram to them, and so that they can,
Can't
while
hear
you
you.
do it, they'll
Can I?
do the discussion. Just show the previous angiographic
Yeah.
appearance for them, for the panel. In fact, for all of us.
I think
So we're going now with a bigger balloon because 1.5 millimeter balloon did this work, although at the end with high pressure it ruptured.
Okay, both are
not
large
going.
vessels actually, and the disease process I recall of the OM3 just
take a
ends
shorter balloon.
or starts
Let
at
us take
the
a shorter balloon, a 2
bifurcation.
millimeter balloon. Yes.
So
Take a 212 or a 210 balloon because 1.5 did go, so it should go.
How about do the anchor balloon technique?
So, Upendra, will you just show the
Okay.
angiographic shot once more, the one you've taken just before all this?
Yeah, give a 2 millimeter balloon.
Just while they're giving you, just show the angiographic shot.
Yes, Dr. Yadav. Taking a 212 millimeter balloon, hopefully it will cross. Once we can dilate it, then we'll go ahead and dilate the restenosis portion of the stent.
Can you hear us? Can you hear us?
Yes. Yes, we.
Dr. Kaul?
Yes. Sir.
Dr. Kaul, are we
Yeah,
audible? He's on.
Okay.
Can you raise the volume a little bit? No, it is also not going.
We have to make sure that we are not going through that struts and take another view and
No, 1.5. 1.5 again.
Give 1.5 again. Give a 1.5 millimeter balloon again because it had ruptured and possibly.
Yeah, we saw it rupture.
But since it had crossed,
Yes.
we
I
need to
think-
do a little more work on
I think
that.
there is an option like after the first you balloon to the instant restenosis and check the IVUS or OCT, the side
Well,
branch
I can't
crossing
hear
guide wire, whether
Ashok
outside
very
stent
well.
or not.
Can they improve the audio?
any thoughts from the panel? He's not able to cross. He's crossed once with 1.5. Two, he couldn't cross. One thing
This
is,
is 1.512.
now you're again taking 1.5 or 2.
ये भी नहीं जा रहा.
ये डबल मार्कर है, ये 2 का लग रहा है.
My feeling is you might not have gone through one of those struts. So
Yes, it is obviously through the struts. And unfortunately, the balloon burst, and that's why it didn't dilate that area completely. There it is.
Finally, it has crossed. Okay.
So this is a
Making it
1.5.
cross was difficult, possibly because it's gone through the strut, and then there is an angulation.
So what size and this is again a 1.5?
Dilated, is it?
Two marker.
this may be 2.
कर लेंगे.
Is 1.5.
It's
Yeah, this is
I
a,
mean, the guide is kicking out a lot,
Yeah,
so
this is
maybe a
1.5.
guideliner or Godzilla may be helpful for this case.
I think in this situation we have to
Yeah.
be careful about the guide wire is going outside the stand and
Did
goes
it
to the
burst
side
again?
branch. But we should make sure the imaging technique like IVUS or OCT, and then you can try again for ballooning to the side branch.
Did the balloon burst again?
no. No, we have already dilated with a 1.5 now, and the balloon.
2.5. Up 2.5 balloon.
Now we'll take a 2.5 balloon, and hopefully it should go now.
Audio is
Yeah.
But direct.
to speak louder.
Oh, let's take a 2.5, but take a shorter balloon.
2.5.
What's happening with the pressure there?
Okay.
He's got his tube open.
No, it looks like a pressure going down.
Oh no, he's got his tube open.
Okay, all right.
Okay.
No, pressure is all right. We had just, the Y adapter was open. Patient is very stable now.
Right. अब चला जाएगा. इसी को फिर उसमें डालना है. सर, वो मेन में.
Yes, 2.5 has gone, so I think we are making a good progress.
That's excellent crossing there with that.
So now we'll dilate it with a 2.5 millimeter balloon. Yeah, go ahead.
Okay. Just a minute.
Yes, that portion. Yes, that's good.
There you go.
रप्चर हो गया.
So was this a non-compliant balloon?
एक 2.5 का दूसरा बैलून दे दो.
Yeah, this is 2.512, but it got ruptured, so we're going to take a high pressure balloon. Give a non-compliant high pressure balloon,
You see, your previous 1.5 both had
or
ruptured
maybe give a
also.
3 millimeter balloon.
Yeah. So we'll take 3 NC and dilate at least 12 atmosphere at the start, so that we can.
Okay, because this is through the strut, so that is the reason.
मेन स्टेप को dilate कर लें.
Let's dilate this and then go to the other vessel. What is this? Okay.
कंप्रेसर में डालना है.
You wrote the bifurcation paper.
Would you like to take a picture at this stage?
नहीं नहीं सर, पहले dilate
So,
करें.
so show us a picture so that we can have the discussion on what we see. Dr. Kaul?
Yeah, we'll show you the picture also.
Yeah, we'll show you the.
Just a minute. Okay. Just yeah. Go ahead. इसको compress.
Somehow, audio, can you improve my incoming audio, because I'm not able to hear what's going on in the hall.
Yeah, can somebody just adjust Dr. Kaul's audio?
थोड़ा पीछे, थोड़ा पीछे.
Yeah, now it's good. The balloon is going very easily.
We'll communicate.
This is a 312.
Proper preparation of the bed.
So we are hearing you well. So you should continue with the.
Okay, good. So this is a 3 millimeter balloon. Yes. Okay,
There is a waste.
that's good.
Now,
I think still there is a waste.
This
in the
time it did
middle.
not rupture.
Can you put it back and see the helical passage?
फिर से dilate कर. Speed up. Yeah, we'll dilate. Redilate. We'll redilate.
I think we will redilate it and see.
Yes. If it crosses, it's a good sign that you have opened up sufficiently.
So it is going in easily. Do it here, yeah. Keep that in portion in the center. Yeah. Can you just change the angle, maybe make it cranial, make it cranial?
Yeah.
Yeah, now,
Yeah, run.
Looks better.
yeah, it looks better.
So what pressures did that take?
Now we go to the main branch.
Give me 2.5 balloon.
What was the
What was the
pressure?
pressure?
Balloon here, or you go straight with the
Not able to.
2.5 NC.
What was the
give a
pressure?
2.5 NC?
Pressure is fine.
Pressure is fine.
No. The pressure of the
Patient's
balloon.
blood pressure is fine.
What was the pressure at which
Oh,
the
pressure at the balloon, we went up to
12 atmosphere, sir.
12 to 14
This
atmospheres.
is 3 balloon.
A 3 millimeter balloon.
Artery is also of 3 size. Yeah, now we'll show the one angio.
Now we'll take.
Yeah. Perfect. So now one, पहले 1.5 दे दो.
Let us go and dilate
Two का
the
दे दो. 2 वाले.
stent.
Two से पहले.
That'll be
Take a 2 millimeter.
Osteas are required.
Sometimes it.
This is the wire, no?
हाँ वो ले लो अब इसको. उसको छोड़ दो. वो अंदर.
I think
Actually,
it's
the
still not.
location of the upper branch is very close to the stent, and I think
After
Part
stent
of it
it
is-
will open well, sir.
Will somebody like to use a angiosculpt or
वही same minute
to prepare that
yeah.
osteum?
Our plan is to do a mini culotte.
A mini culotte.
Before you do that, I think that area is not yet fully opened, and my
We're
feeling
going
is that
now and dilating the stented portion,
Okay.
and we'll again redilate. Yeah.
Stent boost.
Start from here.
Stent boost.
No, start from here. I can see the stent.
तो आगे चला गया ऐसे. आगे चला गया.
Dilate. Okay.
पीछे. Keep it here. Oh, flip कर रहा है.
That's slipping.
Melon seed effect. Yeah. Melon seed effect.
Cutting balloon 2.5 कर ready.
Do it here.
Come back and do it.
ना यहाँ हो गया.
I think we'll take a cutting balloon now.
3 का NC. जो अभी 3 का दिए थे वो दे दो. एक मिनट सर.
Would some imaging be good in this case?
Just a minute.
IVUS?
Yes, we
Yeah,
plan to
we'll
do
put the
imaging.
OCT.
We plan to do the imaging.
OCT कर लेते हैं.
Now we'll do OCT of the stented region, so to see what is the problem.
OCT ready?
Get the OCT catheter now.
Yeah.
Yeah, we can
before
OCT the
OCT, I
both.
think you prepare.
sequentially
Dr.
the
Kaul,
both
you have
branches.
7 minutes left, so I think you first prepare this and do the
Okay.
stenting, and post you
Let's
can
take
do
the
OCT.
OCT catheter.
It won't help much now.
Okay. So we'll go ahead. 3 का NC दे दो. So करने नहीं कोई बात नहीं बाद में करके दिखा.
Chalo.
Okay. 3 का NC.
Let us expand it to the best possible extent first.
312.
And OCT we'll use to finally optimize the result.
So what was that balloon size that you put down? 2.5?
3 is at last.
No, this
First
one.
2.5, now 3 NC.
In
Yeah.
this
Yeah.
OM3.
What was
Now
the
we're taking a 3 millimeter NC balloon for
Now you're
the
taking the 3.
stented vessel.
It seemed fairly fibrotic, to tell you frankly, and I would have thought cutting balloon would have actually been a nice or angiosculpt now, and just go up and really break that lesion.
actually, yeah,
Yeah,
that will be
okay.
required even for the
Because
upper.
That's
will
right.
not-
This lesion by clearly is not broken adequately. Let's see.
I think well opened, sir.
Now it's well opened.
Okay.
Central.
Yeah, different.
Yeah.
Yeah, it's opening well.
Okay, good.
Yeah, you
And-
see well expanded
and-
whole balloon. Yeah.
Plus, there is no melon seed now. There is no melon seed now.
हल्का आगे. Yeah. No, उतना नहीं. और थोड़ा पीछे.
Just a minute. Keep it here. Yeah, it's fine. Because we have to go distal.
Yeah. Okay.
Okay.
Perfect. So 318 giants are fine.
Just dilate this portion also because we're anyway coming here.
Yeah.
And the upper portion also. Because we have to go to the healthy portion.
ठीक है sir.
Dilate here also.
Okay.
Because we have to take a long stent. Okay.
First we'll do mini clot, so we'll do the
So
side.
first again, I think we dilate the.
Yeah. The
Now we'll dilate the side branch
side
again.
for your, so that stent will go.
Yeah, with the same balloon.
Yeah.
So your strategy would be to
Dilate the side branch with.
dilate branch and then stent into the side branch.
Yeah, we put
then
a
we'll take side
stent
branch.
into the side branch first.
Yeah.
We'll
And
do
then
mini clot, sir.
Proximal
out
end of
into
the
the-
stent to be kept touching the circumflex wall.
Can we have an
Standard
angio
clot,
at this
it will be
stage
mini
and
clot.
see?
We're not. Yes.
Yeah, we'll show you, sir. Just give me 1 minute time.
You've already dilated
Now
it with
making
3.
sure that that portion,
Unless you put
that
a angioscalp
suspect
or a
portion of
cutting,
the
it's not going
proximal
to
end
open.
near the ostium of this branch is taking the balloon and opening it well before we venture with the stent. Going very, very easily, dilate it.
Just done, why not? Stop. Just थोड़ा सा.
Yeah.
हाँ, बस ठीक है सर.
Yeah.
18 will be all right.
We're going up to 18.
Okay. ठीक है सर.
So obviously the stent would go now. And
So 318.
let us take a 318 Zines.
One whisper ready रख लेना फिर सर.
Okay. Get the stent now. And then we have to recross, and we'll recross with the whisper. Let's first deploy the stent. Yeah.
Take an angio because you have done
Get the
dilated
stent.
both the vessels. Now let's see how the results are before you put the stents in.
So can we just have an angiogram,
Yeah.
Upendra?
Sir.
Yeah,
Yeah, we'll show the angiogram.
an angiogram, please. Dr.
Yes,
Kaul
sir, showing
can't
angiogram.
hear us.
Yeah.
Okay,
Sir,
good.
Good.
we, well dilated, sir.
So now we will just.
18 or more.
I think in this view, it is
18 will be all right.
18 should be all right.
Okay. Okay.
Because 12 millimeter balloon was appearing very long.
Okay.
Yeah. Because RO caudal view for circumflex, you know, it makes things look quite good.
So we'll keep 2 millimeter inside the main vessel of this stent. So it will touch the opposite wall of the main vessel.
Plan is to make the proximal end touch the opposite wall and then recross it. That's what we discussed, how we'll go ahead and do it.
और थोड़ा सा आगे अंदर थोड़ा सा. और थोड़े-
Just
और
a
थोड़ा
minute.
पीछे-
This should be okay.
थोड़ा और-
Just take a picture.
हाँ, okay, 1 minute sir, पहले मैं बना लूँ. Just a minute, sir. Just a minute. Just a minute. Come on. Done. Stop. Sir, और थोड़ा आगे जाइए. मिनी प्लॉट करना है ना. थोड़ी और.
Take a picture.
और थोड़ा सा अंदर जाइए. थोड़ा सा है हमारे पास जगह. और थोड़ा. या. और थोड़ा सा और सर. थोड़ा सा और. या और थोड़ा पीछे. नहीं, बहुत थोड़ा पीछे. या. या, perfect.
So we're deploying this stent.
So this is mini lot, what we call. Whisper ready? This is 12.
Okay. Going up to
12.
12. Make it 14.
Okay, बस
Keep,
that's all.
keep it there for a few 10-15 seconds. Okay.
आप पीछे डायरेक्ट कर दो. पीछे इससे फिर डायरेक्ट कर दो.
Deflate.
पीछे थोड़ा सा और.
Now we just do a little bit here.
Just a minute. Yeah. So this is just a minute. Follow?
Okay.
Okay, so Upendra,
Give me the whisper.
We're
Now
going to be, you
give a whisper and we'll
continue
cross.
to record. We're just going for
We'll
2
go
minutes
through this stent.
and come back to you for 5 minutes. We're just going away for 2 minutes, coming back to you for 5 minutes.
Yeah.
So what
Call,
have
we are
done,
with you.
after deploying the stent and keeping it proximally into the main vessel slightly, we recrossed through the upper stent into the restenosis stent with a whisper wire, and now we're dilating it with a small balloon to make a passage, and then make the passage bigger, and finally put in one more stent, a long stent there, and then do a kissing to recross the upper branch and do a kissing.
1.5? Mobile. चला जाएगा सर, चला जाएगा, इतना पे डायलेट किया धक्का दे। I think it is. Yeah.
Oh, it has gone. So it has gone. Could you see it?
Yeah.
We saw it.
Stent strut को डायलेट करना पीछे.
Now we're dilating the strut of the stent which had dilated with a 1.5 balloon.
Stop.
It had some problem in going in, but it went.
Just. Okay. Give me the 3 balloon.
यहाँ भी कर लो. Okay.
Okay. 3 balloon. Struts को.
Are we still being seen there in the hall?
Yes, yes, we are. You can hear us?
Okay, good. So I think we make.
Yes, yes, sir.
Yes. I think we're making steady progress.
3 का NC.
So we have dilated it with a 1.5 balloon after recrossing the stent in the upper
3 NC.
branch, and now we're going with the 3 millimeter balloon, and we'll
3 का लंबा stent.
stent it with a long stent
3 का.
from healthy portion to healthy.
338 and 5.
3.338, which I think would be an adequate stent.
And then Sarkis direct.
And then do a simultaneous
Call, you have
kissing
2 minutes left.
after recrossing it. Well, whatever is there is there. Gone.
Got it. Yeah, fine.
So it has gone, 3 millimeter balloon has gone.
Just a minute. डालो. Stop.
We'll dilate it now.
Struts को dilate करना है. Just a minute. एक मिनट.
Yes. High pressure.
पीछे. तो पीछे struts का और पीछे.
Yes.
Yes, keep it. और थोड़ा आगे. थोड़ा आगे सर.
Okay.
Say, just for discussion, would there be any other 2 stent strategy you would have used, Dr. Bell?
What?
Would there be any other 2 stent strategy here that doing a collot? Is there any other strategy you could have tried for this?
Yeah, DK crush will be maybe a better strategy because there is some discrepancy in the sizes and it's just, but it depends on the choice what you
Yeah, sir.
feel
I
better.
like
Yeah.
Head-to-head
But here we
comparisons
decided to
wise,
do the
DK crush
collot.
has
Better than cooler.
better
करने
than
बोलना है
Kurat.
तो उनको.
But it depends on your experience or whatever.
Let us take the stent now.
338.
At the end of the day,
338.
you've got to be expert at,
338.
you can't be expert and say, oh, I'm going to do this and that.
करने
And
के पहले side
today I'm going to be a flavor of the day and flavor of the month. So he likes that. If he's good at it, I think we're very happy that he does a good job.
I think the only
only what-
prerequisite is that you should have equal size vessels if you venture into cullet. That's the most
For the ISR, would the tap would have been a bit more
tap
simpler?
because this is the angle is too narrow. I think if you tap whatever you do, there will be some struts.
Yeah,
will be-
we thought about the tap, but we thought that, this is not the right angle.
Yeah, I think I agree. It's not a good case for tap.
Tap is not
Sir, only two technique is feasible. One is the
mini crush or DK crush. DK crush was the other alternative.
The only problem
So-
in this mini culotte is that, like in this case, if you are not done the pot, recrossing becomes a difficult because you have chosen your stent size according to
We'll do the
distal
pot, sir.
vessels and
What
it is not
3.5 NC ready?
expanded in the main vein.
3.5 जो NC लिए हुए थे वो ready करो.
So you should take a higher
do what,
balloon,
sir?
dilate that portion, then crossing becomes very easy. Like he was struggling because he had not done that, and
Now the stent has gone quite easily.
Sir, वो निकालना है side.
Now we have to take
Side
out the
branch.
other wire. ये ना wire.
Just a minute. Just a minute.
We're taking out the wire.
Yeah, side branch. Yeah. Okay. निकाल लीजिए. एक whisper ready
okay,
कर
Dr. Kaul, we might go off here any time. So I think there is a great case, great learning. I'm sure now few steps are remaining. You will be able to complete it.
Run, run.
Okay.
Yeah, it looks
That's okay.
already very good. Now
That's
you have
okay.
to do a recross and do a final
Yeah.
kiss.
That's right. That's right. That's right.
Just a minute. Pot करना है. एक मिनट sir.
Good.
हाँ, एक मिनट sir. Keep on. थोड़ी देर तक.
Now we'll do a pot.
3.5 का NC.
That's the fibrotic area, which we felt was
Yeah.
the need for a
25 seconds.
cutting balloon.
Run, sir.
Fibrotic area.
Run.
Yeah.
Run. Yeah. I think
So
well
you may
expanded.
go off the air at any time, but we're still watching. It's still coming.
No problem. Yeah.
Okay. Okay. Good.
But thank you for showing a very
Well, this
illustrative and
patient was a
difficult case.